Knee replacement is absolutely a wonderful operation. It gives patients a great ability to move again, but it requires full, jumping in with both feet by the patient. They need to want to get better to make it work. But what we do, it's not really a replacement, it's a resurfacing. And so what we do, I have a nice model here. We actually have a joint. We make an incision in the front of the knee. We move the kneecap out of the way. We bend the knee. We take the measurements of your bone during the surgery, and we actually, I'm going to take this little cap off because that's what it is. What we do is we have instruments that allow us to reshape the end of your thigh bone to the inside shape of the implant. So we're not really cutting off a chunk of bone. It's like taking the sole off of a shoe and applying a new sole onto the shoe. And that's the end of the thigh bone that we replace. And we do the same thing for the top of the shin bone. We shave off the top of the shin bone. We know how much bone we take away. We put a piece of metal and a new bearing on the surface, and then we mate the two together, and we have a nice, smooth, realigned knee that we're allowed to have our patient start to walk on. And in most cases, we also resurface the backside of your kneecap with a piece of polyethylene plastic, which is also a new bearing, which allows the kneecap to rub against the new implant here. And a lot of patients will say, gosh, my knee clicks now. But that's what happens when you have a piece of metal clicking on a piece of plastic. And so we like it when that happens because that means the knee is probably on its way to healing. Most patients start ambulating the same day as surgery and are able to go home in the first 24 hours. We have great partners in our anesthesia department that partner with us that are able to give our patients nerve blocks, which block the nerve that goes to the knee so that postoperatively they can rehabilitate with less pain. We also use different kinds of medications given orally that kind of work in tandem with each other to also mask the pain of surgery so that you can start therapy and maintain therapy immediately and the immediate perioperative period. And most patients, by the time they get to 6 weeks, are not taking any medication at all. So that program works very, very well. Recovery is, I've had patients that say, this is one of the hardest recoveries I've ever done if they've had previous surgery, but they're usually very, very happy and very engaged, which is very important. It requires focused physical therapy. There are some therapy programs which I like, which incorporate something called closed chain exercises, which actually works all the muscle in the extremity in tandem so that you're actually exercising the whole extremity, not just the knee. And that's very important to get the function back. Usually by 6 weeks, most patients are up walking, sometimes with a cane, but most of the time without. And they're still urged to continue therapy afterwards until about 3 months. Most patients return to work between 8 and 12 weeks if they have a desk job or an office job, and then after 12 weeks if they have a little bit heavier work. But the knee requires about 8 to 10 months to really, really get fully rehabilitated, because it's not just the knee that requires the rehabilitation, it's the entire extremity. There is no surgery that doesn't have any risks. The biggest risks that we worry about the most are infection and stiffness. Infection risk in a healthy patient is about 1%. And that usually requires further surgery to take care of the infection, oftentimes requiring removal of the implant and then waiting till the infection is gone to reimplant a new knee. But fortunately, it's a very, very small risk. There's a very small risk of blood loss today because we have new medications that prevent blood loss, and the way we do the surgery, because of the technology, you just lose less blood during the surgical procedure. There's a risk of getting blood clots. This is why we put patients on an anticoagulant after surgery and why we urge our patients to keep moving, because that'll help prevent that. Those are probably our biggest concerns. Knee replacements, we know from multiple studies, and we're talking about implants that were done 20 years ago now. 90% of implants we know are still functioning between 15 and 20 years after they're implanted. Unfortunately, that other 10% will require another surgery in that period of time, and if you do, revision surgery in the right hands also goes very, very well.